Dear students, welcome to this virtual 319 lecture. This is week 8 and we will be talking about assorted chronic inflammatory processes. Please remember, these are the lecture slides, not the examination slides. We have a separate video with the examination slides explained elsewhere. So let's start with the inflammatory nasal polyp. This pathologic process has already been touched upon, I think, in the second or third week. So here we see a big piece of inflamed nasal mucosa. So how do you define a polyp? A polyp is a macroscopical term, meaning that there is an elevation of the usually a mucosa or the skin above the layer that it should be. So it's just an expansion with a stalk. Now let's have a closer look at it. We check out the surface epithelium. Here the surface epithelium is ciliated respiratory epithelium, multi-layered. Here are the cilia. Sorry for the strange section. It's a bit thick. In the previous case, in week number 2 or 3, we also had areas of squamous metaplasia, which unfortunately we don't have in this. But what we have a bit more prominent is the edematous stroma. So here we have basically interstitial edema of the stroma. This is a huge lesion, so this patient probably had trouble breathing through one of their nasal cavities. And this is why they complained about it. We zoom in, you see a lot of edema, and you see mixed inflammatory infiltrate, which contains eosinophils in large numbers, indicating an allergic etiology. But you also get a lot of plasma cells. Here there are some, and small lymphocytes. So it's a subacute to chronic inflammatory process. I will just check if we see any Russell bodies. Who knows, maybe there are some. Let me just breeze through it. But you can see Russell bodies in the other slide from the previous lecture. So I hope your Russell body needs will be satisfied with that slide. Let's see here. There's a lot of inflammation. There is some neovascularization. So in inflammatory processes you can have fibrosis and you can have a development of new vascular spaces. So no Russell bodies yet, so I won't be wasting any more time on this. Let's move to the next. Herpes of the skin. This is an acute viral infection by herpes virus. Herpes tends to infect epithelium. You can see herpes labialis when you get it on your lips. I guess most of you know it. It's just a nuisance, nothing else. But what is even more of a nuisance is herpes genitalis, that tends to be much more serious and harder to treat. In case you do wrestling, you can get herpes gladiatorum. And you can also see herpes on mucosa of internal organs. You can see it in the esophagus, and you can even see it in the vagina or on the uterine cervix. So herpetic infection can be seen a few places. You can also have a systemic herpetic infection. This is serious, especially in immunocompromised individuals like newborns or in people who have HIV or have suffered some kind of stressful event. This can be herpetic meningoencephalitis, herpetic pneumonia, or herpetic hepatitis. This tends to be quite serious in contrast to herpes of the skin. And you can have also herpes zoster, but it's caused by varicella zoster virus. So let's just check out the skin. You probably know how a herpes looks like. It's a vesicle. So what happens is that here we have the epidermis. This is the normal one. And if the keratinocytes get infected by herpes, they undergo acantholysis. It means that the joints between the keratinocytes just fall apart and the keratinocytes just scatter like here. the keratinocytes just scatter, and you get an intraepidermal blister here. And what really helps us to say that this is herpes and not something else are these cells. You can see that the nucleus is a bit strange. This is a viral effect, so these keratinocytes have been infected by the virus and you get these nuclear inclusions. Here you see as well, this nuclei look strange. This is exactly how the viral effect looks like, the viral cytopathic effect. Let me see another one. I think there were even some better than this, maybe on the other side. Here you can see that the epidermis, as it has undergone acantholysis, it has also undergone necrosis. This is just coagulative necrosis of the epidermis. You see here that the nuclei are missing, the nuclear staining is missing. So this blister is quite large, it's going to pop anytime, and here you see already that the epidermis below is regenerating, so this is reepithelialization of the defect. So here we see a lot of nice things going on at the same time. So herpes simplex, let me see, here are these cells. This is nice viral effect. It has the ground glass chromatin. It means that the detail has been lost. The nucleolus, which is inclusion-like, and there are multiple nuclei. Here there are 2 nuclei within one keratinocyte. So this is what happens when you infect a keratinocyte with herpes virus. So this is a nice case. You will see it a lot, but you will almost never take a biopsy from it. We sometimes see like a herpetic infection on the cervix if a biopsy is taken from a cervical ulcer on the uterine cervix, but other than that we don't really encounter it. This is more of a special thing from us, maybe that's the reason why you have it there. So let's move on to another slide. This is a bit less interesting than the previous one. This is chronic urocystitis. This means that there's a chronic inflammation of the urinary bladder. There can be many different causes, usually linked to urine retention, most frequently encountered in people with prostatic hyperplasia. But you can see it also in people with polyneuropathy from diabetes, or in people who have had injuries to their spinal cord and cannot really empty themselves. So in these cases, here this is a very serious chronic urocystitis. So one of the things that is interesting, that most of the urothelium is gone. So this is an area of urothelium which is still there. Here you see the umbrella cell. So this is how a reactively changed urothelium looks like. And due to the chronic inflammation, something interesting happened to it, and that is squamous metaplasia. This is squamous epithelium, non-keratinizing, and here the squamous epithelium has also spread into the so-called Brun's nest. B-R-U-N-N, Brun's nests. This is something that we see normally in the mucosa of the urinary tract, especially the bladder, and here the squamous metaplasia has spread to it as well. And if you look really close, you can see that neutrophils are getting into this epithelium. This means that the process, the inflammatory process is both chronic, so it's chronic urocystitis, but there's also an acute exacerbation. So the inflammatory process is both chronic but also active. So both chronic and acute at the same time. So this is what I would say that is interesting about it. There are other changes which are a bit beyond your level of basic pathology, so I will not be discussing that. So remember, chronic inflammation can lead to squamous metaplasia of the epithelium. Here's another big tract. Once again, the neutrophils getting into it, and this chronic inflammation can also have an acute component. This is, I think, the most important takeaway from this slide. So let's switch to another slide. Chronic gastritis. This is going to be much more interesting for you for several reasons, including that it's an examination slide. So here we have small fragments of the mucosa. This is usually what you get during endoscopy. Typically we get just 1 or 2 fragments. Here we have how many? 7 fragments. This means that the clinician has been really generous with us. Thank you, clinician. And now we check out what's wrong with it. So this is mostly pyloric mucosa, but you can already see that it's quite purple. It's purple because there's a lot of chronic inflammation. So there's a chronic component to this gastritis. The chronic component is determined by the presence of small lymphocytes and plasma cells, which there are plenty. And in every case when we describe gastritis, here's the plasma cell, then we check both for the chronic component and the acute component. And the acute component of the inflammation is made up by neutrophils. So we always look for neutrophils. So here's the neutrophil. Here are more neutrophils. Some of them are getting into the epithelium. Here's another one. So this is both chronic but also acute inflammation. So this is chronic active gastritis. This is quite significantly active. So I would bet a lot of money that this person has Helicobacter pylori somewhere. So if there is a lot of Helicobacter pylori, we can sometimes see it in the H&E stain. I would say maybe this is a Helicobacter pylori here. Maybe this one here, but I'm not sure. In order to highlight them, I would use special stains like Wharton Starry or Giemsa stain. But here in this case, here you see a few more. If you see them like this in the hematoxylin eosin section, then you can bet that there are a lot of them. So this is quite intensive Helicobacter pylori associated gastritis. And if you really keep your eyes open, then you can also find something else. And that is here. You see here these glands, they look strange. You see these cells. These are goblet cells. So what we see here as well, goblet cells here, here, and here a bit more. These ones are emptying themselves. So this is intestinal metaplasia. This one is nice here. Some distended goblet cells. So this is intestinal metaplasia, and this is linked to the chronic inflammation caused by H. pylori. So this is a beautiful case of H. pylori associated chronic gastritis. These patients are treated with antibiotics. And because of the presence of intestinal metaplasia, they need to be followed up regularly to exclude dysplasia and further like gastric ulcers and so on. So this is a nice case. And let's check what happens if this festers for a longer amount of time. I'm going to talk about chronic ulcers of the stomach. So this is another beautiful case. This is a surgical resection specimen. So here we see mucosa of the stomach of the pyloric type. You see no corporal glands. You see the picture is very similar to the previous one. There's a lot of chronic inflammatory infiltrate with some acute components. Here we see some neutrophils. So this is both chronic and acute gastritis. So this is a bit of corpus, and we are in the pylorus, and here we see the same picture as before with the intestinal metaplasia. So it's just the same. I'm not going to look for H. pylori in this case because it's not all that relevant. Here's a nice lymphoid aggregate with a follicular center. That's also typical for H. pylori. Now I'm going to resist and not look for it, because the big problem is this crater here. This is a huge ulcer in the pylorus. You see here all this crater. This is a big chronic ulcer. It's chronic because you see a lot of scar tissue formation and because it has a crater-like shape. The acute ulcers, they are usually flat and they don't look like craters. So crater-like shape, and here you see the muscularis propria, these thick bundles of smooth muscle, and they suddenly get lost here because the ulcer has eaten through the muscularis propria and the ulcer gets into the submucosa. No, sorry, not submucosa, but into the subserosa and adventitia around the stomach. I think this one is going towards the retroperitoneum mostly. And here we see the problem that the patient faced, and there is a huge muscular artery with a fresh thrombus within its lumen. Remember, here's the fibrin mesh which has entrapped a lot of blood, and this patient, if I recall correctly, presented with hematemesis. That means vomiting of fresh blood. So this patient presented with acute symptoms endangering this patient's life. So this patient was operated and they performed acute life-saving like emergency resection of the pylorus of the stomach, because the ulcer was so big and the bleeding was uncontrollable by endoscopic means. I think this one ended badly for the patient. Unfortunately, a patient got a shock with multi-organ failure and didn't make it. So this is a textbook example of a big chronic ulcer which can kill the patient. So now let's check out the ulcer a bit closer. On the bottom of the ulcer you can see exudate. Here you see a lot of neutrophils and macrophages and fibrin. Here's the fibrin. See the fibrin mesh with the neutrophils and different inflammatory cells. Here are some neutrophils. So this is the bottom. Then below this exudate, below this debris, you can see the non-specific granulation tissue. This is the thing which happens when the organism is trying to heal itself. So granulation tissue is the universal healing tissue, and if it goes well, then the granulation tissue matures into scar. So here you can see a lot of scar tissue, but unfortunately the process, the chronic inflammation, couldn't be really stopped by the attempts of the organism. No matter how much scar tissue has been developed, the chronic inflammation was going on and couldn't be stopped. And unfortunately, in a different section, not in this one, but in a different section, the ulcer has managed to reach this big artery, and this caused the bleeding. So as you can see, gastric ulcers are quite important, and the suture and the treatment of gastric ulcers is the most important surgery that is performed on the stomach, well, besides resection of cancer. So remember this is an acute emergency, and you will be seeing this a lot during surgery, and unfortunately some of the patients are not going to make it. So nice slide. Once again, let's recapitulate. Chronic ulcer, it's chronic because there's a lot of fibrosis and scar formation, as you can obviously see. This ulcer has penetrated through the entire thickness of the wall of the stomach, and the bottom of the ulcer you can see necrotic debris with fibrin and granulocytes, and below it you see granulation tissue. Here you see some adipocytes still remaining, so it has gotten into the fat. So here you see the granulation tissue, and as you go deeper you can see that it has turned into scar. This is very cellular scar tissue, and this was the attempt of the organism to stop the ulcer from digging any deeper, and it has unfortunately failed. So let's move on to the next slide, which is Crohn's disease. So now I'm going to tell about the idiopathic or inflammatory bowel disease. It's shortened for IBD. In the spectrum of IBD, you see two conditions, Crohn's disease and ulcerative colitis. They are quite different in their clinical course, so I suggest you to check out the theoretical part. We talk about these two diseases quite extensively during our practice, and you should be aware of their basic clinical features in order to distinguish them. These diseases are rising in incidence, especially in the young population, so maybe some of you youngsters already has it. It starts at a young age, it can start in the teenage years, and these are very unfortunate diseases, especially Crohn's disease, which can cause a lot of suffering to the patient. It leads to early patient demise very rarely, but it can make the life quite unpleasant, especially if they are having some kind of flare-up. So let's check out Crohn's disease a little bit, and then we will check out ulcerative colitis. So Crohn's disease, it likes to affect the small intestine, especially the terminal ileum, which I'm going to guess this is the terminal ileum. So you can see immediately that the mucosa is quite hyperplastic. It has been quite widened, enlarged by the inflammation. So we go close. Here you see, here we have some epithelium with very serious reactive changes. A lot of granulocytes are getting into the epithelium. And if we check here, you can see that the epithelium is missing. This is all ulceration. So the epithelium has been ulcerated away, so this patient probably had blood in the stool. Patients with IBD, they usually have bloody diarrhea, let's say 10 times a day. That's quite typical. So there's huge ulceration. And there's a lot of granulation tissue here. You see, this is all granulation tissue. You see the blood vessels and a lot of inflammatory infiltrate, which is quite dense. It's mixed, mostly lymphocytes and plasma cells, but also many neutrophils, especially at the ulceration. So one of the signs of active IBD is ulceration of the mucosa. These ulcerations can be quite deep. So this ulceration happened above mucosa-associated lymphoid tissue or MALT. So in this case, it could be called aphthous ulcer. Aphthous, A-P-H-T-O-U-S, aphthous ulcer. This usually happen in the distal ileum. And here we can probably guess that a hyperplastic mucosa and the chronic scarring, here you can see it's quite scarred, and a lot of lymphoid infiltrate has caused the stenosis of the lumen. So you can see that there's a very tiny lumen remaining, so this patient probably developed the ileus because of the blockage of the passage of intestinal contents. So the first operation that these patients have to endure is resection of the terminal ileum, and then they are prone to developing strictures and stenosis in other parts of the gastrointestinal tract, so they usually during their lifetime undergo multiple operations. This is one of the most important complications of Crohn's disease, but you can read about other ones from your seminar notes. So once again, just a recapitulation, it's in the acute phase. These diseases tend to have acute phases. Basically, they tend to have bouts of acute disease, which either is stopped through pharmacology or it stops by itself. These bouts last for a few weeks, maybe months. So this, the sign of activity is usually ulceration of the mucosa, that we can see plenty of ulceration here also in other parts. This disease is characterized by multiple episodes, multiple flare-ups, and periods of remission when there is no activity, there are no ulcerations, and after multiple of these episodes, the mucosa becomes extremely scarred. Here you see an area where you have some crypts left, and the other areas where the mucosa has completely lost its architecture. Remember, the intestine looks totally different. Once again, just check out some normal pictures and you will see the difference. If you weren't really like in knowledge of the origin, then you wouldn't be able to say that this is probably the small intestine. At least that is my guess. But there are very heavy chronic changes, both acute and chronic changes. So remember what I've told you about these diseases. They are quite unpleasant. They have episodes of flare-ups and varying periods of remissions. So if a patient is really lucky, then this patient will have only one episode for their entire life and then they are alright. If they are unlucky, they will have multiple episodes along the years, and they will gradually lose parts of their intestines because they become stenotic and nothing will pass through. So that's quite unfortunate. Now let's check out the other end of the spectrum, and that is ulcerous colitis. Once again, I suggest you to read about the theory regarding this from your seminar notes. I will concentrate on the microscopic changes. Here we have mucosa of the colon. We start by small magnification. This is a bit more of a chronic case, but also has acute activity of the disease, as I will explain. But what I want to illustrate here are the so-called pseudopolyps. So what happens with ulcerative colitis is that some parts of the mucosa, like here, undergo atrophy. Like here, this is atrophic, and other parts of the mucosa, like here, this and this, they become hypertrophic. So you have atrophic and hypertrophic parts, and this gives the look of the mucosa. It will look like cobblestones, and this will look like polyps, but these are not really like true polyps. We call them pseudopolyps, inflammatory pseudopolyps. So as this patient has probably experienced multiple flare-ups of this ulcerous colitis, then some parts of the mucosa have undergone atrophy, others are hyperplastic, and this gives an uneven polypose look to the mucosa. Now let's go closer. What are the pathologic changes? Well, first of all, there is some disease activity. The epithelium is missing here. There are some neutrophils. So there are erosions. So there is acute activity within the mucosa. And we have also some signs of chronicity. So what happens is that the crypts, the Lieberkühn crypts, they normally look like test tubes, so they should be parallel to each other. They should be parallel, but these ones aren't. These ones are running quite irregularly. You see they are branching, some are larger, some are smaller. These are signs that this patient has suffered previous episodes of flare-ups, of attacks. And here's another nice deep ulceration. So what's the difference between an ulcer and an erosion? An erosion is a shallow loss of epithelium and mucosa, and the maximum depth of an erosion is the lamina propria mucosa. And if you're talking about ulcerations, then the ulceration gets at least into the submucosa but can go deeper. So this is an ulceration because it goes into the submucosa. So remember the difference between an erosion and an ulcer. So this one is an erosion, here this long one, because it goes just into the lamina propria, and the one that I've shown you here, this is an ulcer because it goes into the submucosa. Okay, let's get back to the ulcerous colitis. So there are both acute and chronic changes, and what you're going to see in endoscopy are going to be the erosions and ulcerations and the inflammatory pseudopolyps. Alright, I think I will just jump back to the previous slide for a second because I forgot about something. So I need to tell you that in Crohn's disease, another thing which you can see are granulomas. So now I'm just going to check whether we have granulomas here. Those granulomas are different from tuberculous granulomas and different from sarcoid granulomas that we have already talked about before. You get it like 50-50, so in 50% of the cases you have them, in 50% you don't. And so far I'm not having luck with it, so I'm going to say this is a case where we don't have granulomas. I mean, granulomas are not compulsory, their presence is not compulsory for the diagnosis of Crohn's disease, but it's a nice bonus when you have them, and unfortunately I don't see any. So this concludes the part on Crohn's disease, and let's get back to ulcerative colitis. So in ulcerative colitis, I've already talked to you about signs of chronicity, and that is the change in architecture of the Lieberkühn crypts, and now signs of activity. So one of the first signs of activity is the presence of erosions and ulcerations that is very nicely visible here. The second sign of activity is the presence of cryptitis. Cryptitis means that neutrophils are getting into the epithelium of the crypt, which I think unfortunately in this slide we don't have. but you can find cryptitis. No, unfortunately we don't have it here. I mean, you can't have everything in one slide, you need to be really lucky, but you can look up cryptitis in Google, or you can find it in a textbook, what it looks like exactly if you're interested. If not, then just learn that you have cryptitis. We describe it as pathologists. So these are the signs of activity. And now what's the problem with a mucosa like this? You see it's very uneven. So especially in ulcerative colitis, if you have long-standing disease, there's a rather high cumulative risk for developing colon cancer. Like after 20, 30, 40 years of this disease, you can develop colon cancer. And if you have such an uneven mucosa, then it's very hard to say whether it's a pseudopolyp or whether it's a precursor lesion like an adenomatous polyp. So detection of dysplasia in long-standing cases of ulcerative colitis can be quite difficult. So in these cases, what the clinician usually does is that they take biopsy samples like every 5 to 10 centimeters from the colon. So the pathologist is going to have a lot of fun going through 30-40 samples like this, but it's for the good of the patient, not for the feeling of the pathologist. So let's move forward. So hepatitis C. So now I'm going to talk about pathologic processes affecting the liver. So let's start with viral hepatitis. You know there's A, B, C, D, E hepatitis, and in our population the acute hepatitis is hepatitis A. You get it through the fecal oral route. If you don't respect the hygienic standards for food preparation and so on, we get sometimes smaller epidemics here in certain ethnic groups. Hepatitis B and hepatitis C, they are seen mostly in drug abusers in this country. In other Western countries, you can see a lot of hepatitis B, especially in immigrant populations from Asia, China, Mongolia, Vietnam, these countries, that's very widespread there. Hepatitis C, mostly drug abusers, but you can get them in people from some Arab countries. I think Egypt has a huge toll of hepatitis C in their population. They had some kind of mishap with a vaccination and they accidentally infected a lot of people a few years back. It's an interesting episode, you can read about it. And hepatitis D, it can coexist only with hepatitis B. And finally hepatitis E, which is usually acute. You get it, for example, in India. I think it's from the fecal oral route. It's usually a bit more difficult infection than hepatitis A, and it's extremely dangerous, especially for pregnant women for some reason. And now I'm going to talk about chronic hepatitis, which is hepatitis C. But hepatitis B is also very similar to this picture. They are quite similar to each other, so you distinguish them clinically by performing a serology for hepatitis B antigens. And you can perform PCR to detect the copy number of hepatitis B and hepatitis C viruses. So let's check out this case. This is going to be an autopsy case of, I think it was a younger gentleman who had a drug habit, an intravenous drug habit, and he died of hepatitis. So first thing that you can see here is that there are these purple-blue areas. These are the portal tracts. So chronic hepatitis tends to affect the portal tracts mostly. The portal tracts are full of lymphocytes, and here you can see that they are also enlarged. So they become star-shaped. Look at my cursor. They become star-shaped and enlarged. So this is hepatic fibrosis. Some of the portal tracts are significantly enlarged. Look at this, like a star or maybe an L, but it's star-shaped. Some of them are quite enlarged. So this is hepatic fibrosis. This is not cirrhosis yet because you don't have the nodules. But had this patient lived for a few more years, then this patient would have developed cirrhosis. You can see here there's an almost complete bridge of fibrosis, This is the first thing that we check, the amount of fibrosis. And the other thing that we check is the activity of the hepatitis. This is a bit more advanced, so I will. This concept is a bit more complicated, but I will try to explain it. So when you look at hepatitis chronic, then once again you judge the fibrosis and you also judge the activity. And the activity is seen at the border between the portal tract and the hepatocytes. So here, this area here, this is the area where you judge the activity. So when your hepatitis is active, then the lymphocytes are jumping out from the portal tract and they are spreading among the hepatocytes. So here you see them jumping out, surrounding hepatocytes and causing damage to them. Here you see some lymphocytes getting out, damaging the hepatocytes. This is the so-called interface activity. So whenever here's the hepatocyte which has undergone apoptosis, I think, or it's starting to undergo apoptosis, and here are some lymphocytes getting out and destroying them. So this is the so-called interface activity, and this means that this hepatitis is active. And from this very serious hepatitis, this person developed liver failure. I think this person died of liver failure. So this person hasn't made it to cirrhosis yet. As you can see, these findings, they are a bit mild on the first look, but they are quite serious. So we would expect this person to have elevated liver enzymes, elevated hepatitis C count. Hepatitis C RNA is elevated. I think it's measured like that. RNA is measured. And then this person could also have cholestasis and other signs of liver failure. And now we move on to the terminal liver damage, and that is hepatic cirrhosis. Hepatic cirrhosis is the end stage liver damage. It can be induced by different causes. In our country, the most common is alcoholic cirrhosis, but you can get it from chronic hepatitis, chronic cholestasis, some rare metabolic diseases like Wilson's disease, hemochromatosis. So you have multiple reasons. Not everybody with cirrhosis is an alcoholic, but in our population, most of them are. So we start by low magnification. You can see the nodules. There are multiple nodules surrounded by a lot of collagen tissue. So these are the cirrhotic nodules. The hepatocytes are forming the nodules and they are surrounded by complete bridges of newly formed collagen. This gives the nodular appearance to the cirrhosis. This is just collagen full of some inflammatory cells. Here you see some hepatocytes have steatosis. This might be due to localized metabolic impairment, but it also could be because this person drank before that. We will never know. So this person had cirrhosis, but we can also see signs that there was very heavy, very serious liver failure before that, because in the middle of the cirrhotic nodules we see very progressed, very serious regressive changes within the hepatocytes. There is vacuolization of their cytoplasm. In some cases you even see like a necrosis beginning, like here the cells are falling apart. So this person had chronic liver failure due to cirrhosis, but it underwent one last flare up before death. I mean, there are many different ways you can die of cirrhosis. Most people die of some kind of bleeding complication, like bleeding from esophageal ulcers, but you can also die due to mineral disbalance when you get ascites formation. And here in this case, this person died of a simple liver failure. Here you can see in the middle of the nodule there's necrosis of the hepatocytes as one last flare up of the chronic liver failure. People who have early cirrhosis, which is still compensated, can be transplanted, but people with a decompensated cirrhosis, they cannot be really saved. The performance of the patient is rated based on the child puke classification. This is clinical, it's not histological. In many cases, people can survive with cirrhosis for decades, or it's just incidentally discovered during autopsy. In other cases, they die of it very quickly. It's very individual how it goes. So now I will just show you a special stain that we use to highlight cirrhosis. And in order to highlight for cirrhosis, we stain for reticulin. Reticulin, or collagen 3, is a special type of collagen. Most collagen in the body is collagen 1, that is quite like structural and elastic a bit, and the reticulin 3 is a bit more stiff. And in the liver there is normally a lot of reticulin 3, which is arranged, if you look at this, when you take just this area, then you can see that the reticulin is just surrounding the cords of hepatocytes. This is how normal liver would look like, so if I got just this picture, I wouldn't even suspect that something's going on. But when we zoom out and we check out the bridges of collagen among the nodules, you can see that there's a lot of reticulin as well. So this is abnormal. So when we see this bridge formation, we can see with confidence that this is hepatic cirrhosis. So this is just the reticulin stain. It's a silver impregnation technique. Now I think this is the last slide, and this is acute pancreatitis. This is another thing that you will encounter a lot, especially in the ICU. This can develop due to blockage of gallstone within the ductus coedochus or within the ampulla of Vater. That is biliary pancreatitis. But you can also get it due to an episode of acute alcohol abuse, or in some cases you get it just spontaneously, especially in people who are obese, who have hypercalcemia. So there are many triggers for acute pancreatitis, but in most cases it's either biliary or due to alcohol abuse. Let's check out the slide. Here we have some fatty tissue and some pancreatic tissue. We zoom in. Here you see the Langerhans Island, and here you see the secretory acini, which contain the granules of the enzymes, the proteolytic enzymes. And the problem starts when these proteolytic enzymes get discharged and they start digesting the cells themselves and the surrounding fat. Here is the fat starting to melt. Let me find an area of fat which is alright. So this little area of fat is alright here as I zoomed in, because most of the fat is affected. And as the enzymes spill out, the adipocytes, they just start melting apart. This is the process of saponification. I have already touched upon this in a previous slide. But this case is extremely serious because you see that most of the fat is melting away in this fashion. This is all fat within the pancreas itself. So this is a fatty atrophy of the pancreas, and as the enzymes were released, the pancreas is digesting itself. Here you can see very nicely the adipocytes have died. They have changed their colors. Here you see the inflammatory infiltrate. So this is all simply just liquefactive necrosis. So if this patient survives, then all this area of liquefactive necrosis will just melt away, and what you will have left over is a pseudocyst. A pseudocyst is an empty space which contains either it's totally empty, it can be collapsed, or it can just contain interstitial fluid or some necrotic debris. So pseudocysts develop after episodes of acute pancreatitis. Then they can be quite large because their contents are hypertonic, so they always suck in the water, and they can grow quite large. Sometimes they have to be removed. But in this case, I think the patient hasn't really made it. This is acute pancreatitis with necrosis. So acute necrotizing pancreatitis, remember it's a form of liquefactive necrosis due to release of the proteolytic enzymes and destruction of the pancreatic parenchyma and surrounding fatty tissue. This process can be extremely aggressive. It can melt the retroperitoneal fat quite extensively and can lead to abdominal shock, abdominal compartment syndrome, and so on, and many other ugly things that you will learn about in internal medicine. So this is it for this lecture. Thank you for your attention.